Hello, good evening, good morning, good afternoon for to all of you wherever you're staying from your home or your comfortable place to join our webinar. Welcome to our ninth ICTEC updates in hand surgery. So with us, we have already Professor Hyun Baek from Seoul, Korea. Professor Baek, good evening.
Good evening.
How are
Good to
you?
see you. I'm fine.
Good to see you.
Thank you.
Well, after some time, then I'm very happy to meet with you again, although it's only a virtual meeting. Yeah, although both of our countries got the second wave or maybe more in Korea. However, we are happy to share the experiences through this webinar. And I do really thank you for your generosity by accepting our invitations with this webinar. Indonesia,
it is my honor. Thank you.
Yeah, Indonesia is now the top in terms of the number of cases that we got, but we do believe that we could manage the situations. All right, ladies and gentlemen, just would like to introduce Professor Baek. Professor Baek is professor in the Department of Orthopedic Surgery, the Seoul National University, College of Medicine and Seoul National University Hospital, a very famous hand surgeon across the world. Now, let me give you the list why he is famous and very knowledgeable person. He is the current editor-in-chief, although is going to step down, of the Journal of Hand Surgery Asia Pacific volume. He's also the immediate past president of the Asia Pacific Federations of the Society for Hand Surgeries, and also immediate past general secretary of the International Federations of Societies for Surgery of the Hand. He is the past chairman of other societies, the National Society, the Korean Orthopedic Associations, Korean Society for Surgery of the Hand, and also Korean Microsurgical Society. Wow, all prestigious positions. And also amazing publication he has made, 388 original articles. Wow. So without further ado, we trust you that you are going to enjoy the presentations, the lecture by Professor Baek. Hyun,
Yes.
shall we start?
Yes, please.
My talk consists of introduction, parents who have children with congenital hand differences, patients living with congenital hand differences, surgeons who treat patients with congenital hand differences, and summary. The prevalence of congenital hand and upper limb differences has been reported from 5.25 to 27.5 per 10,000 live births. Among them, polydactyly of the hand is most common in the United States of America, Sweden, Western Australia, and South Korea. Recently, my team investigated the epidemiology of congenital upper limb anomalies in Korea. It was a nationwide population-based study. We analyzed congenital upper limb anomalies patients' registry for 10 years, from January 2007 to December 2016. We could get raw data from the Health Insurance Review and Assessment Service of Korea. It was a retrospective cohort study. 10,704 patients were included in this study. Boys were more common than girls. Mean annual instance of congenital upper limb anomaly was 23.5 per 10,000 live births. The annual instance was significantly higher in boys than girls. Polydactyly was most common and followed by syndactyly, limb deficiency, and other anomaly. 44.6% of the patients had operative treatment within minimum 3 years of the diagnosis. Proportion of patients who underwent surgical treatment was significantly higher for polydactyly and syndactyly, but it was significantly lower in limb deficiency and other anomalies. Among the parents who had operation, 21.5% underwent multiple operations. The proportion of patients who underwent multiple operations was significantly higher in syndactyly, but it was significantly lower in polydactyly and other anomalies than rest of the congenital upper limb anomaly patients. When a baby was born with congenital hand difference, the parents may suffer from significant agony. This sense of loss can be reflected as denial, anger, distress. They must cope with stress, disappointment, and challenges which may lead to serious crisis or even disruption of a family life. The babies with abnormal hand or hands will seek simple factual explanation of differences between one hand and the other, or their hands and those of their friends at 3 or 4 years of age. The stress related to congenital hand differences, such as functional deficits, hand appearance, social interactions, and emotional reactions, were reported in 58% of the children or adolescents with congenital hand differences. It is necessary to understand the psychological and social aspect of the parents who have children with congenital hand difference, as well as the patients themselves. Surgical goal for congenital hand difference might be improvement of function and appearance of the hand. To improve results in surgery for congenital hand difference, not only the surgical aspects, but also psychological and social aspects of the parents and patients should be considered. According to the Encyclopedia Britannica, the cosmetic surgery is defined as the surgery for the enhancement of normal structures that are subjected to age-related changes or that have unusual features that are distressing to the patient. In Wikipedia, it is said as a voluntary or elective surgery that is performed on normal parts of the body with the only purpose of improving person's appearance and or removing signs of aging. Then, I have a question. All the operations for congenital hand difference are cosmetic or aesthetic surgery to improve personal appearance or to remove aging signs? Maybe not. The man above looks 20 years younger after surgery, and the girl below became more beautiful after surgery. These are typical pictures of cosmetic surgeries. This is a photo of a patient with a cleft hand. Left hand of the patient was not reconstructed. The patients might have significant difficulties for daily life. Can we call this as a cosmetic surgery? This is a photo of a patient with bilateral triplicated thumbs. After surgical reconstruction, functional appearance of the patients was much improved. Is it a cosmetic surgery? The surgery for congenital hand difference cannot be simply described as cosmetic or aesthetic surgery. To improve surgical outcomes of congenital hand difference, good understanding of psychological and social problems of the patients and parents, as well as the role of the surgeons, are very necessary. So, I think and insist that it is rather the surgery for aesthetic function and psychological and social adaptation. Let's assume that my baby or grandchild was born with congenital hand difference like agenesis of thumb or macrodactylis in these photos. It will be more than a shock. Whole family may suffer from sadness and distress. Some may feel they were cursed. When a baby is born with an obvious physical difference, the parents have to deal with the loss of their anticipated normal baby, and they need to make the adjustment to their actual baby. Many of the parents go through 5 stages of shock, denial, sadness and anger, adaptation, and reorganization. Prenatal ultrasound is the primary modality to detect fetal anomalies. However, the detection rate of upper limb anomaly is low. The sensitivity for the fetus affecting the digits were only reported from 4 to 19%. The parents may be angry because the prenatal ultrasound scans could not detect a hand deficit. When there is a consultation for this problem, the surgeon should explain that the prenatal diagnosis of a congenital difference of the hand is very difficult even by the expertise of obstetrician or radiologist. The parents of a congenital hand difference showed a higher level of psychological distress than parents of a healthy baby. Mothers reported more adjustment difficulties than fathers. Only 57% of parents were recovered from the psychological distress at 6 months after birth. 26.6% showed patterns of resilience. However, 15.2% of the parents were suffering from chronic adjustment difficulties. In a study of my team published in 2019, Parenting Stress Index score among 89 mothers of children with congenital hand or foot differences was 73.9, which was similar with those of parents of children with congenital heart disease and craniofacial anomaly. 17% had a clinically significant level of stress which might need special counseling to reduce parenting stress and to improve the resilience. So I think it is important that the screening test for the parents' stress be performed to find parents who may need psychological and emotional support. I think the role of grandparents is very important, especially in Japan and Korea. When grandparents see a baby with congenital hand difference, they may say, "Look at the baby. We are all finished. How can the baby survive?" These grandparents hurt baby's parents more than anybody. On the contrary, the grandparents can say, "Is the baby all right elsewhere? Then the baby will be fine. Don't worry." These grandparents encourage baby's parents more than anybody. Parents who have a baby with congenital hand difference should face with important decision making on the management of the child's condition on behalf of the child. There are 3 types of decision making in the physician-patient encounter. First is the paternalistic type, in which hand surgeon makes decision for patient. Second is a consumerism type, in which parents or patients make decision. They used to consult the surgeon to obtain information. Sometimes this type of parents visit a lot of specialists and analyze the opinions from them. Third one is a shared decision-making type. It is a combination of above 2 models. Consumerism type of parents may offend the hand surgeon because they sometimes say, "A doctor of other university said a different opinion from you. Which one is correct?" In this situation, we should be calm down and explain the advantages and disadvantages of different procedures to help the decision-making of the parents. Problems of children living with congenital hand difference begins with development of self-consciousness or mismatch between demand and function. Reliable self-recognition is developed by 2 years of age. The child notices the difference but is not concerned about the difference. At age 3 or 4, the child seeks explanation of the difference between one hand and the other, or their hands and those of their siblings or friends. At age 4 to 6, the children enter the kindergarten or the elementary school. They need communication with a peer group, and their social environment is not protected by the family anymore. Any questions about the hand from other students may cause distress and frustration. It is common for them to hide their hands in the pockets. They gradually understand that the hands will not be normal. The loss of hope for normal hands may lead to regressive behavior, anger, withdrawal, and tearfulness. The child may not wish for the growth of a normal hand, but wish for the acceptance with pride by the family, especially from the mother. Warm responses of the parents and the family are very important at this time. Encouraging the children by warm concern, talk, affection, acceptance, and support can have a significant effect on outcome. In a clinical study of 14 children with congenital hand defects who received microvascular free toe transfer, parental adjustment to the hand was an important independent variable in determining psychological outcome. The children of poorly adjusted parents had more social and psychological problems before surgery and showed an increase in behavioral problems after surgery. There was a long-term follow-up study of 25 patients who underwent toe-to-hand transfer. Although most of the patients and their parents thought the surgery had improved the acceptance appearance of the hand and the hand function, 82% of the parents said patients' postoperative hand looked worse or very much worse when compared with a normal hand. However, only at 24% of the patients responded postoperative hand looked worse or very much worse than normal hands. From this study, we know that parents concerns the cosmetic appearance more than the adolescent patients with congenital hand difference. Children with congenital hand difference reported decreased upper limb function but better peer relationships and positive emotional states compared with population norms. However, children reported more pain and poorer physical functions when their both upper limbs are involved, or malformations involve entire limb, or there are comorbidities in heart, GI tract, etc. Personally, I think there may be cultural difference between Eastern and Western hemispheres. Probably, the children living in Asia may feel more stress. The patient with congenital hand difference will have experienced a lot of physical, psychological, and social problems. The deformity, which can be improved by proper surgery, is not only goal, but the goal understanding of the patients and human beings might be the way we should pursue. There have been some reports of analysis of function and cosmesis after surgical reconstruction of radial polydactylies. Late Dr. Ogino's group reported an analysis of 113 children who were operated for radial polydactyly. 88% were satisfied with the surgical outcomes, but 12% of them dissatisfied. Unsatisfactory results was relatively high in fossil type 3, 5, and 6, and triphalangeal type thumb polydactyly. It was higher when the ulnar digit was removed than when the radial digit was removed. In an analysis of 19 patients of radial polydactyly with average 22 years of follow-up, 95% satisfied functionally, but only 63% satisfied cosmetically. There was a report in that 20 children were operated for radial polydactyly. 35% of the patients had complaints. 25% of patients were self-conscious about their appearance and 20% having been teased at school. Complaints were common in fossil type 4 patients. Another report investigated 33 thumbs in 31 patients. Only 33% were okay with the surgical outcomes. Thick thumb was complained by 1/3 of the patients, angular deformity in 18%, shape or contour problems in 15%, nail abnormalities in 6%, and decreased IP flexion motion in 6%. This was a 4-month-old baby who had atypical type of radial polydactyly. Her proximal thumb was severely flexed and the nail was hypoplastic and deformed as seen at yellow arrow, but had a good articulation with trapezium. Distal thumb was a kind of a floating type, but showed better appearance of the nail as shown at the green arrow. The quality of the films are not good because these were taken 18 years ago. Anyway, preoperative X-ray showed proximal thumb of right hand was hyperplastic than left thumb, and there was no bony connection found at the distal thumb. On-top plastic was performed. Only top portion of radial thumb was excised, and distal part of ulnar thumb, including nail, was transposed. A longitudinal Kushner wire was inserted between two parts. 9 years after the operation, tightening of first web space and zigzag deformity of the reconstructed thumb was observed. So first web space deepening, derotation and corrective osteotomy of first proximal phalanx and corrective osteotomy of first metacarpal was planned and performed. These are the photos taken in the operating room. First web space was deepened and widened. Angular deformities at IP joint and MP joints were corrected. 17 years after the first operation, the patient became 18-year-old young lady. She decorated each of her nails beautifully in different colors and shapes. Because of a good stability and motion of her basal joint and MP joint of the reconstructed thumb, she could make a good grasping and pinching. She could touch the tip of little finger with reconstructed right thumb, but could not touch the volar MP joint crease of little finger. Thus, opposition of the reconstructed right thumb showed more than 7 points of Kappanji score. When the patient and her mother visited my clinic in last August, mother said to me, "Thank you very much for your excellent operations. I'll never forget your help. You saved my girl." I told the mother that I did my best to improve function and appearance of your child. I am proud of the surgical outcome. However, the patient said to me, "Well, I know my hands looks much better after surgery, but I want my hands look normal." I think this is a real situation of most of the patients who had operation to correct congenital hand difference. Next, I'd like to discuss surgical outcome of polycization in children with congenital hand difference. It is reported that the general outcome for non-radial club hand associated thumb reconstruction was satisfying. However, a significant worse outcome was seen for functional and subjective evaluation in the radial club hand associated with thumbs, and for the functional score for the more severe blows type group. In a long-term follow-up study of 11 patients who had polycization, the polycized index finger gives good results in isolated thumb agenesis, but the results are less reliable for those with radial club hand. This study suggests polycization of isolated thumb agenesis may yield good surgical outcome. However, when it is associated with radial club hand, the outcome may be less favorable than that of isolated thumb agenesis. 31 polycized digits in 26 patients were analyzed to assess the aesthetic outcome of polycization. A surgeon, therapist, and caregiver completed visual analog scales to subjectively assess the aesthetic outcomes. Higher VAS score means better aesthetic outcomes. The VAS scores averaged 6.4 for the surgeon, 6 for the therapist, and 7.3 for the caregiver. The most significant abnormal features are decreased girth, excess length, and angulation. However, this study did not include the opinion of patients themselves. In an analysis of 10 hands in 8 children who had a polycization procedure, and they were evaluated 3 to 15 years after the surgery, polycized hands had poor strength and performance on functional tests, but 6 of 10 polycized hands had normal dexterity score. Thus, polycization procedure may help to enhance dexterity of the hand, but not the strength and performance. There was a study which compared index polarization and microsurgical second toe metatarsal transfer for thumb reconstruction. They concluded that the patients who received the toe transfer had higher parental satisfaction and performed better in some activities of daily living. This was a study from Taiwan. Taiwanese may prefer 5-fingered hand than polycized 4-fingered hand, like other Asian people. If the same study was performed in Europe or America, there is a possibility that conclusion may be different from this study. This is a 15-month-old boy with complete ageness of left thumb and associated radial club hand. Left wrist was radially deviated and the forearm length was shorter than right side. The index finger of left hand was well developed but little hypoplastic when compared with normal right index. An active motion of the finger was good. In the left wrist, distal radial epiphysis was not observed and radius was shorter than ulna. Index polycization was done. Polycized index was well positioned in good pronation. Immediate postoperative radiographs showed good alignment of a polycized index finger. When soft tissues of the base of index finger is well sutured to the joint capsule of the trapezium, a Krishna wire fixation is not necessary, as shown in this case. 5.5 years after the polycization procedure, reconstructed thumb was slender and looked a little longer than normal thumb. Pinching and grasping of polycized index was excellent. It is a surgeon's thinking. A new basa joint of the polycized index was remodeled nicely and it was stable. Mother of the patients was satisfied with the function and cosmesis of her daughter's polycized thumb. She thought that her daughter is normal except wearing a glove. Many people even do not notice when shaking hands with her. I told the patients and her mother that you are an example of best outcome in my experiences. However, the patients told me sometimes I feel sad because I have only 4 fingers and asked me, can I have 5 fingers when I grow up? This was a really tough question to me. I answered her, it is impossible to make you 5 fingers now, but we will have a better medicine and science in near future. You may expect benefits of a future technology of robotics and tissue engineering. So don't give up your hope to have 5 fingers. It was my answer. The patient with mild congenital hand differences had better self-concept and psychological well-being scores than those with severe differences. Some of the patients with mild congenital hand differences present with more significant psychosocial and behavioral problems, while others with severe differences present relatively less social and psychological problems. For example, the adults with Apert syndrome had adapted remarkably well despite significant functional deficit. This was a 1-year-old boy with radial polydactyly. The epiphysis of distal phalanx of the ulnar side of the thumb was delta-shaped as indicated by a yellow arrow. It was an abnormal triangular epiphysis, but when I operated this boy almost 20 years ago, I could not recognize this abnormality. So I excised extra radial thumb and did corrective osteotomy of proximal phalanx for abnormal triangular epiphysis. This film was taken at post-op 6 months. The alignment of thumb looked straight. 5 years after the operation, abnormal triangular epiphysis of distal phalanx became prominent and caused angular deformity at the interphalangeal joint of the thumb. So I corrected the deformity by intraepiphyseal corrective osteotomy. 13 years after the osteotomy, good bony alignment was maintained. Active range of motion of reconstructed thumb was almost full. Personally, I thought the surgical outcome of this patient was excellent, but the patient was complaining that the right thumb looked thin and slender. He was not satisfied with the surgical outcome. This was a 13-month-old boy with type 3 apert hands. His hands were scooped and showed rosebud or horse hoof deformity. Nails of first, second, third, and fourth fingers were fused to form synonychia. Little finger had its own nail. Distal phalanges of thumb, index, long, and ring finger were fused to form a bony mass. Fifth ray showed complete syndactyly, but distal phalanx was not fused with fourth distal phalanx. I have operated 11 patients of Apert syndrome. He was one of the toughest cases. It was not easy to identify each ray of the finger because distal phalanges were fused to form one large bone. Well-designed skin and soft tissue flaps to recover the osteotomized raw bone surface was very necessary to avoid skin problems. After multiple operations, all the fingers were separated bilaterally. Because of the bony symphalangism at interphalangeal joints, there was no interphalangeal motion of all 10 fingers. Metacarpophalangeal joint showed little motion. All the fingers were separated. Function and cosmetics of both hands were not good. But the boy looked very happy, and his mother was happy too. Then, the boy wanted to have 10 toes too. These are the medical photos of his feet. Only a fourth web space was barely observed. Other web space showed complete syndactyly. Although the nails of each toe were separated, bony anomalies of the phalangeal and metatarsal bone were observed. Both first proximal phalanges and first metacarpals were delta bones, causing angulation, deformity. And also there was noted bony symphalangism of right second metatarsophalangeal joint. Metaphalangeal bones were not seen in four lateral toes bilaterally. When he was 4 years old, he could have 10 toes after multiple operations on his feet. These medical photos were taken when he was 9 years old. Mother always bragged about her son. He can write and play piano. He is doing fine at kindergarten. Mother always said what he can do, not what he cannot do. I told the mother and patient that hand function as well as foot function is not good enough to do sports activity or skillful motion. However, you can do daily activities of living. The boy and his mother was very happy to have 10 fingers and 10 toes. For hand surgeons who treat patients with congenital hand difference, trust from patients and parents is very important. Without this trust between surgeon and patients, we cannot expect good surgical outcomes. Some bad terminologies can hurt patients and the parents. Central deficiency of the hand may be better terminology than lobster claw hand, cleft hand, or split hand. Cerebral palsy is another example. When a doctor tells parents your baby has cerebral palsy, the parents may feel brain function of the baby is paralyzed. As we know, intelligence of cerebral palsy patients are usually normal. Mischosen medical terminologies can make further psychological damages and subsequent loss of trust of the parents and patients with congenital hand difference. It is important to hand surgeons how to interpret the psychological aspect of children and their parents with congenital hand postoperatively. In a study of the toe to hand transfer in children, 10 years follow-up of psychological aspect, a high level of satisfaction was reported in terms of function, appearance, donor site, psychosocial well-being, and the reactions of others. It was concluded that the positive effects of toe transfer surgery are enduring at a long-term follow-up. 90% of parents and 95% of patients thought surgery had improved or very much improved hand function. However, when they were asked, how do you think the appearance of the hand after surgery? 77% of parents and 91% of patients thought that surgery had improved or very much improved the appearance of the hand. However, when the parents were asked how they thought the appearance of their child's hand compared with a normal hand, 82% of parents said they believed that the child's postoperative hand looked worse or very much worse. 48% of patients thought that their postoperative hand looked worse or very much worse. Personally, I think a psychological stress of patients with congenital hand difference and their parents may be bigger than reported in the literatures. They may pretend that they are doing well functionally and socially. However, the pain in the heart may be much significant and may last longer than we think. The hand surgeon should keep in mind that their pain, and we have to try to help surgically as well as psychologically. Parents want to know genetic inheritance, whether the siblings or descendants of the affected baby will be okay or not. Knowledge on basic genetics is helpful to build a good rapport with the parents. Family history is one of important clues. We can use a personal memo which summarizes genetic inheritance of congenital hand difference, or we can get information from the website like Online Mendelian Inheritance in Men. Surgeons' understanding of the pathologic anatomy of a hand is very important for surgical planning, in which the surgical timing is better to be postponed until it is clearly revealed. Earlier surgery is recommended when surgical planning is completed and the structures of the deformity are large enough to manipulate surgically. Theoretically, the early surgery can prevent emotional scarring related to a child's awareness of the deformity. Children of age 1 to 3 years, they may have some incomplete understanding of the surgical procedure and may be able to express fear or distress. At age 3 to about 6, children tend to accept simple and clear explanations of the procedures, and it may be good age for the operation because it can be completed before transition to school age. There has been no general agreement on timing of operation for congenital hand differences. It depends on general condition of the patients, priority of surgery in patients with multiple associated anomalies, and most importantly, surgeon's experience and preference. However, it is necessary for surgeons to understand psychological aspect of the parents and patients. Sufficient and thoughtful discussion and explanations with the parents and patients may improve surgical outcome. It is hard to find level 1 or 2 studies on the congenital hand differences because it is clinically diverse and rare. Most of the published articles are based on the experience of the surgeons or the institutes. Thus, evidence-based data are the way we should follow. However, the experience-based data are also important in this field. Even the experts may have difficulties in decision-making of certain entities. SNS among the surgeons who are interested in congenital hand differences is a very helpful and effective tool for communication of knowledge and experiences. There is an international group of hand surgeons who are interested in congenital hand difference. When a member faces a challenging case, he or she used to ask questions to other members. I'd like to show you an example. I modified the original email to protect the privacy. Dear friends, I need to ask for your help with the following case. I've recently seen a 4-year-old boy with a congenital palmar subluxation of his left wrist. All of his joints in the upper limb and lower extremities are hypermobile, and therefore we asked his pediatrician to look for a joint hypermobility syndrome for example, Ehlers-Danlos syndrome. The wrist is almost passively reducible. The reposition causes him some discomfort. Resistance of the palmar soft tissues can be felt, due probably to a shortened palmar capsule. To put the wrist in a normal relationship, I'm thinking about lengthening of the palmar soft structures, reposition with strengthening of the dorsal capsule by incision and doubling. But would that be sufficient? Do you think that this could work, or do you have any other ideas? Looking forward to your reply, and I hope you are all well. All the best. The following was a response from a member. This email was also modified. I would consider two possibilities in children with non-traumatic carpal subluxation in whom the soft tissue ligamentous constraints have become lax. One is children with trisomy 21 Down syndrome. Just as ligamentous laxity leads to cervical spine subluxation in these children, they can develop non-traumatic radiocarpal or endocarpal subluxation dislocation. It is often bilateral, outplane radiocarpal fusion when there is more ossification present. The second is due to a monoarticular or polyarticular juvenile idiopathic arthritis. A comparison X-ray of the opposite side will often demonstrate the relative advanced skeletal maturity of the affected side. Referral to a pediatric rheumatologist should be considered before any surgery. I hope this is helpful. Looking forward to our next in-person meeting. SNS communication among the parents and the patients with the same disease, such as Apert syndrome, arthrogryposis multiplex congenita, brachydactyly, congenital constriction band syndrome, is very helpful to introduce and join other family with the same problem. When parents visit clinic with their baby for the first time, it is recommendable to tell them, if you don't mind, I can introduce families who have the same or very similar conditions with your baby. This is a photo of 3 children with Apert syndrome and their mothers. They communicate each other through SNS and come to cheer each other when one of them needs surgery or outpatient clinic visit. They say, we are a big family, actually, more than a family. This girl is middle school girl who had more than 10 times of operation for her hands and feet. Now she has 10 fingers and 10 toes. This is 8-year-old girl who also has 10 fingers and 10 toes. Looks very happy. This is 2-year-old girl. She is on the way to get 10 fingers and 10 toes. This is an 8-year-old boy with arthrogryposis multiplex congenita. He was playing drums during the opening ceremony of the 11th International Federation of Societies for Surgery of the Hand Congress, which was held in Seoul 2010. He had multiple operations, including dorsal wedge osteotomy of the metacarpal bones, tendon transfers, and elbow flexoplasty. He was using thumb index side-to-side pinching to grab the drumsticks. Now, he is a college boy with bright personality. I promised him to be the marriage officiant for his wedding. 2 girls with brachydactyly are playing piano after separation of syndactylies and the lengthening of the proximal phalanges. It was more than 10 years ago. Both of 2 girls are beautiful ladies now. In summary, the surgeon who is planning a surgical intervention for the child with congenital hand difference should widen the view to pay attention to the child's family, especially to the parents. When the parents and/or the patients show significant distress, consultation to the psychologist is necessary. Satisfaction of the parents and the patients are much more valuable than those of surgeons. In African proverb, it is said that it takes a village to raise a child. I think it is even more true that it takes a village to raise a child with congenital hand difference. Thank you very much for your kind attention.
Wow, ladies and gentlemen, let's give big applause for Professor Hyun Baek. Dr. Baek,
Yes.
you pointed so many important points for us, especially hand
Thank you.
to deal with the congenital hand differences. Like the theme of our webinar here is that we do really see that parents and patients demands very high expectations to get the outcome, which might be in a gap difference with many doctors if we do not, as doctors, if you do not realize the points that you have presented. Congratulations for taking up all the points that are important as I demand this topic on congenital hand differences. Goyant, you have
Yes.
so extensive experiences, and we got here the first questions that come into the box. It's actually about consultation, so I may delay to respond or to bring up these consultations. We will discuss the content first, and then later on we will take these important questions for Pak Fernando Junaidi. Sorry, Pak Fernando, so be patient. We'll take your questions soon. All right, so let me just start with the burning questions. It is interesting to know that polydactyly is on top of the incidence among other congenital hand differences, like you presented with statistic data. Many people thought syndactyly takes possession as the most cases, as the report could be drawn from most populous countries such as China, India, Indonesia, and Brazil, as an example. Unfortunately, we do not have yet such a good data, especially in my country, in Indonesia. Although the data is epidemiological data, could it be possible that other factors explaining this fact? Although it is difficult to be certain, I know, whether genetic and hereditary factors play significant roles in the countries of origins of the authors that you pick the literatures, the US, Sweden, I think Western Australia and South Korea itself. Comment on that?
I think there are many factors because congenital hand difference is kind of a combination of multiple risk factors. For example, little finger polydactyly is very common in African people, but the little finger polydactyly is very rare in Korea and Japan and China. So that means that some genetic predisposition can play a major role. And then your question is that in certain countries, polydactyly is the most common, but in other countries, syndactyly is the most common. So I could find some kind of large population study from several reports, but I could not find any report from other countries. So I presented data of USA and Australia and Korea and some other countries, but I could not find any database studies on this prevalence of certain countries' congenital hand difference. So I think if you study the Indonesian experience, probably you will you can say that in my country, syndactyly is the most common, but you have to do the study.
Yeah.
Because I just follow the literatures, and in most of the literature said polydactyly is the most common.
Yeah, right. You are correct. So that's why I wonder why people see most about syndactyly around, but then, you know, the fact that in the literature it's mentioned that polydactyly is the top one. And also you did your national survey, and it's very obvious. So based on your national survey, it also shows that multiple operation is more to patients with syndactyly.
Yes.
The percentage is considerably high. I believe it's not less than 20%, something like more than 20%.
There are several reasons for that, because just if you have one web syndactyly, but some patients they have multiple web syndactylies.
Right.
That kind of syndactylies needs a staged operations. That's why they have multiple operations. The other one is that when you operate the syndactyly patient in a very early age, there is a big chance of web creeping, which means a recurrence of the partial syndactyly, which may need a second operation afterwards. So I think why in syndactyly patient we have multiple operations. Number one, sometimes the patient have multiple syndactylies in both hands. The other one, the syndactyly can be reoperated because of the web creeping.
Right, right. You are correct, and it's very reasonable. Now, let me also elaborate this area. Do you think that kind like soft splint could help to prevent web creeping in this, small children?
I don't have any experience about that splinting, but to my hand, I think actually I tried to analyze the cause of the web creeping after syndactyly release, but I could not find any risk factors for that. Only I know is that when we separate the syndactyly in very early age, like less than 1 year of age, then that children may have a bigger chance of web creeping than the patient who operates after 1 year of age. So I think syndactyly, in certain syndactyly type, for example, if the thumb and index finger is syndactylized, it can be separated very early because to preserve the thumb function. But if it is on the third web space or other web space which is not important than the first web space, probably it's better to wait till 1 or 1.5 years of age, because that can cause little web creeping after surgery.
Right. So especially in my own experience, the upper hand is, oh gosh, very frustrating if after, performing that difficult surgeries and then you got web creeping for the next steps of the surgery. Oh my God, seems like the post-surgery looks useless. Although it's in our perceptions, the parents may not, see that that is going to be a problem, but, in our perception, it's a failure. However, on the other side, with other type of syndactyly, which is not upper hand, I have managed myself for the past decade that in neighboring 3 fingers or 3 digits to be in the syndactyly, I do the one-state procedures to separate both of them. However, I practice myself under non-tourniquet technique, which is good so far in my hand. So would you comment on that, whether it's coming into the one-state procedures for 3 digits?
Yeah, I think there are a lot of myths and facts in the literature. For example, in the literature, most of the literature said that if you divide 2 adjacent web spaces, then the central digit can be jeopardized because the blood supply can be damaged. But that's a myth. But I think it's like a case by case. When I separate the syndactyly, I just press the web space with thumb and index a little bit. And then if you feel some space, which means some loose syndactyly, then you can separate all the web space at the same time. But if it is tightly syndactylized, so you don't have any space between 2 digits, very tight, I think there's a big possibility that those syndactylized fingers may have vascular abnormalities. In that case, it should be very careful to separate the adjacent web space simultaneously. So it depends on the patients. I agree with you that if you are very confident about the vascular anatomy, you can separate all the web spaces at the same time. But the problem is that if you want to separate all the web space at the same time, you need a huge amount of full thickness skin graft.
Right.
So if it is staged, then you can take the skin from the previous scar. So you can just make a same size of the scar, whatever you take the skin from the inguinal area. But if you want to separate all the syndactylized web space at the same time, you need a huge amount of
Skin graft.
skin graft.
Right, that's correct. Yeah, it's also controversial whether you would apply full thickness as the dogma or the main principles, or you would compromise yourself with a split thickness skin graft to give you room bigger for large amount of skin graft. Okay, so we got also the questions. Unfortunately, this is in the chat box, but it's okay.
I can see it. Is that the question from Dr. Penny?
Yeah, right. So it's
Okay.
about type 3. I think this is about syndactyly. How do you recognize the vascular anatomy of the hand? Whether you would apply CT angiography?
Okay, I think he has two questions. One is the
timing.
right time, yes. If it is a syndactyly surgery, as I mentioned before, I think after 1 or 1.5 years of age is the good timing of surgery. There are two reasons. Number one is that the possibility of web creeping. The other one is the possibility of general anesthesia toxicity. Because we know that when the young baby whose age is less than 3 years, when they have a general anesthesia, some scientists they argue that their brain function can be damaged a little bit when the baby have general anesthesia before age 3. But in certain other groups, they said that if the operation is like 1 hour or less operation time, it is okay. But if it takes more than 3 hours, then there is a possibility that the brain damage can be occurred by the general anesthesia. So I think there is no general consensus, but many people believe that less than 1 hour surgery is okay, but more than 3 hours surgery is not okay if the patient's age is under 3 years. So two reasons. I think web creeping can be decreased if you operate the patient with syndactyly at age of 1 or 1.5 years, after 1 or 1.5 years of age. And the number two, you can decrease the risk of general anesthesia toxicity to the brain. So I recommend 1 or 1.5 hour old, maybe at a good time for starting syndactyly surgery. The second one is the how do you know the vascular anatomy? Actually, several decades ago, many people did angiograph to identify the vascular anatomy of the digits. But recently, there were only few people do that. I think if you separate syndactyly in staged operation, you don't need any worry about that, because there will be a collateral circulation. But as Teddy mentioned, if you want to separate adjacent two web spaces, you may need some knowledge about vascular anatomy. So to my hand, if you operate the syndactyly, you can observe the distal arteries. So you cannot, if you do not damage the distal arteries, it's okay. So that's the one of the answers. But the other one is that, as I told you, if you press the web space with the index and thumb, if you feel some space between fingers, that means, I guess, vascular anatomy is normal and good. But if the syndactyly does not have any space between two fingers, so it's very tight, I cannot meet the thumb and index fingers through the syndactyly site, then I think there may be some vascular anatomy. If you want to separate that type of syndactyly, is very you should be very careful. I think I could recommend to identify the distal vessels first, and then separate the syndactyly later.
Yeah, so is on the other word that you rely on your physical exam to make sure that your syndactyly is, could be considered as simple syndactyly by the skin bridging only.
Yes.
Right. And the second point is very important to be very skillful and delicate with the surgery and very clear with the structures so that you could make decisions. If you could identify the vasculature, then you could do, in one state, provided that, you are very, very good in identifying the vascular anatomy. Hyun, in regards of the timing, it's very debatable because,
Yes.
yeah, as an example, I just take the practice of plastic surgeon as an example in performing cleft patient. Only with cleft lip and palate, children may need several surgeries. And what's the timing to start the surgery? 3 months. That's actually for the lip surgery, and that's very controversial. And some of the experts, including in my practice, I become quite early with the syndactyly, especially with the a bit of multiple problems with the output, for example. Then we could delay in 1 year, but in many others, in 6 months to 12 months would be okay. So one of the advice is about 9 months, but I need to come with my own study. Well, hopefully in the future, but I cannot be quite very convincing because I haven't made my own study with the this potential damage or problem by the toxicity of general anesthesia. But you are pointing very important aspect. Thank you for that. Okay, so ladies and gentlemen, you're welcome to post more questions. Okay, so Dr. Baek, as you have
Yes.
explained also the importance to consider the psychological as well as social aspects, besides taking surgical aspects into our attentions, do you have a set or a kind of typical recipe of doctors in terms of attitude when the first time, the attitude from the doctor side, when the first time we meet with the parents and patients? Do you have typical way of responding the parents, consoling the parents? It was the first time you meet them.
I think it takes time when the parents who has baby with congenital difference visit my clinic for the first time. I used to offer a lot of time to explain the situations because first of all, I like to say to the parents that it is not your fault. If you have a congenital hand difference baby, many parents, they do have some guilty feeling because they thought they did wrong during the pregnancy, so that's why the baby is not normal. So I used to say the parents that it is not your fault, and then nobody knows why this difference happens. Number one is the reassurance. The guilty feeling of the parents is not a good thing. So I'd like to remove the guilty feeling of the parents first, and then I used to give them hope because they do need hope because they already distressed and disappointed with the appearance of the baby who was born with congenital difference. So I'm not lying, but I'm trying to give them some hope to the parents. And then I used to tell the parents, there are a lot of parents who have the same or similar congenital hand difference babies. That can be some help to the parents. So number one is the persuasion of the parents, remove the guilty feelings and give them some hopes. If the baby, the children with congenital differences are growing, then I used to tell them the similar things. Future medicine is coming, and then now is the best I could do. But 10 years later, 20 years later, when you grow up and you became 10 or 20 years old, probably there will be future medicine. So I try to give them hope, but not lying.
Right. Right. Thank you very much. That's very cool. My own practice, I have also the adagium, taking lessons from so many people that grown up with these congenital hand differences, but they are very skillful. I even give the assurance that, even they have, people, so-called people could call it as, lobster claw hand. And I have, 5-digit hands. He or she play piano and I don't. And give the baby or the children full capacity to grow and develop is the key, very important. They could be a president of any country, like, in Indonesia, then.
That's right.
I mean, yeah, to boost the feeling of the parents. Well, thank you very much. And
You're welcome.
all right, so, okay. Do we see more questions here? All right, so here again from the same doctors, which part do you separate the syndactyly of type 3? What does it mean with the type 3? Is there any differences, the preference of the separation in older patients? Would you respond on that? I'm not quite sure with the meaning.
I cannot catch the question. What was that?
Yeah, in the Q&A, if you could read, because I just read it, which do you separate the syndactyly? I think it's not very clear, but then is there any differences, the preference of the separation in older patients? I do not really understand as well. So what do you
all the patients?
Right. Okay. So later we will invite the doctor to clarify her questions. Okay, now let me again bring the discussions into these simple questions. Do you see that your attitude in regards of gesture, expressions, choices of words are different in meeting the first time patient and parents or with the caregiver when they come at the older age? For example, when the patient is already in school age or even in
I see.
Right.
I think it depends on the country situation. In my country, it is quite rare when the patient congenital difference visit in older age. So most of the patients visit in a very young age, like months or less than 1 year of age. So I don't have much experience about the patient with congenital difference in older age who visit my clinic for the first time. I don't know, but I think that grown-up children already had suffered a lot of psychological stresses and some social maladaptations and that kind of psychological stresses. So I think the same principle. We have to get some trust from the patient with a good rapport, and good rapport can be taken from long time conversation and try to understand the situation of the patients, that kind of things.
Thank you. Okay, so my assistants, would you invite Dr. Fanny to go into the panelist room so that she could clarify the questions? In the meantime, I would ask the questions also to Professor Baek.
Yes.
Do you see difference in the family or parents' nuances when you compare patients with syndactyly and polydactyly? Averagely, you see the stress and psychological burden is just similar.
Actually, we did not separate the patient polydactyly and syndactyly. So I think it is very hard to differentiate the amount of stress between congenital hand anomaly entities. So I think if you like to compare the psychological stress among different types of congenital hand anomalies, that kind of a study, I think
very tough.
It's very hard to do because congenital hand difference patients number is very small, And if you divide them into several groups, then the number of the patients will be very small to make a good study. So most of the studies dealing with this type of psychological stress, they just make a category like upper limb anomaly or lower limb anomaly.
Right.
So they do not separate each entities. So because the limited number of patients, and also
Right.
if you have a lot of patients, probably you can plan to study that kind of individual cognitive hand differences studies. But in my country, we have only 50 million people in South Korea, and we used to have 1,500 congenital hand anomaly babies a year. So that number is quite small. But you have a lot of population, so you can do that a specific type of study.
Yeah, our problem is that, even though our population is huge, but, it's across a huge archipelago as well. Okay, we have here Dr. Fani. So good evening and welcome. So could you please clarify your questions?
Good afternoon, Prof. Bu and Doctor. Sorry for my English. Actually, still
No problem.
Still related to the previous question. In type 3 congenital heart deformity, which part do you separate first in bilateral type 3 congenital heart deformity, hand deformity? And then, is there any differences, preferences of first separation syndactyly at in type 3 CHD cases in older patient? Sometimes in Indonesia, the patient came to us in older age, more than 1.5 years old. So, is there any different principle of the first separation, Prof?
Yes, you are asking the patient with Apert syndrome, Apert type 3 patients. Type 3 congenital hand difference. What does that mean? I mean, Apert hand has all fingers are united as one finger.
Yeah, Dr. Fani, could you clarify what do you mean with type 3? Is that about Apert hand? Apert hand?
Yes, Apert hand.
Yes, Apert hand. If you have just a simple syndactyly of all the fingers, the textbook used to say that two-stage operation. One is the number one is the first web space and third web space, and the second stage, second web space and fourth web space. This is the stage the operation of a simple complete syndactyly of all 5 fingers. But if you have Apert hand, the nails are fused and bones are fused, but the little finger is always separated. Of course, the skin is syndactylized, but the bony fusion is not exist in the fourth web space. So it is very easy to separate the fourth web space. The problem is that if you would like to separate Apert hand, you cannot make the same principle with the simple complete syndactyly, because you have to separate bones, and then you need a flap to cover the robot area. There are a lot of skillful techniques you may need, and then it takes a lot of time. So to me, I think thumb and little finger is most important in Apert hand, because if you have a thumb and little finger and the 3 unseparated finger mesh, then you have 3 digits. So you can use 3 digits like this. So I used to separate first web space and fourth web space, then separate second and third. Of course, it may take more operation, like not 2-stage operation, but 3-stage operation, maybe.
Okay, so thank you very much, Dr. Funny, and thank you to Amit for joining our sessions here.
Thank you,
Okay.
Prof. And
Thank you.
Dr. Baek,
Yes.
the statement that surgery for congenital hand differences is surgery for aesthetic functions and psychological and also social adaptations
Yes, correct.
is very nice concept. Do you have special reason by putting the word aesthetic proceeded the functions? I mean, you know, the word aesthetic is earlier than the functions. Is there any specific reason behind your, you know, way of putting that word aesthetic?
I'm not good at English, but I think the people who use English as a mother tongue, they should make proper words for that things.
Okay.
For example, surgery for aesthetic function, social adaptation, psychological. This is too long, so you may need new words to describe that. It is not cosmetic or aesthetic surgery. Of course, one part of the surgery is aesthetic and cosmetic, but most of the operation is for social adaptation and psychological stress, to relieve the psychological stress and also function.
Yeah, it's very difficult because, you know, we bring the functions at the top priority, while at the end of the day, patients and parents may bring the aesthetic concern of.
That's right. That's right.
Yeah, in my own experience, I will bring the patients and parents to agree upon the concepts to put function, more abilities to use the hand, more than the aesthetics, like, you know, mostly doctors would perform or would do that. Aesthetic would be like, you know, a compromise to put next after the functions. And I also applied it in burn hand surgery, complicated burn hand surgery. Oh, no way for me to put the first, you know, concerning aesthetics. Top is the functions. What more is the psychological adaptations is placed forward to the aesthetic concern. It's also very important because, you know, yeah, many parents will hide the baby's hand and don't realize that, you know, if they don't change the attitude, it grow even much longer than expected, and the baby is actually limited by the exploring the world with his or her existing hand problem. This is based on the fact that only a few cases of congenital hand differences may end up with beautiful hand appearances by ignoring the scar, including, you know, let's say mild post-axial polydactyly as an extreme example. You know, they don't really concern because it's only very tiny scar on the ulnar side. But other with complicated hand problem, you know, that situations cannot be denied. Do you have any further comment on this?
Actually, I think most important thing is that the encouragement by family, especially by the parents. As you told, if the boy or girl hide their hands in the pockets, I used to blame the parents. You should not do that. You should not do that. Because baby needs first encouragement from the mother, then from father, and then from the family, and then from the friends and other colleagues. So most important thing is that the encouragement from the mother and father and families. So if they give some good encouragement to the baby with congenital hand difference, they used to show some brightness in personality and also in expression.
Right, thank you. So before I continue with my concern by, you know, getting you busy with my questions, I would take this consultation from a participant here in the Q&A. He has a daughter who was born with anomaly of the left hand. She doesn't have normally grown 5 fingers. The left hand has 1 thumb, which is smaller than the normal thumb, and doesn't seem to have a strong bone as well. A bit flail, maybe flail. The other 4 fingers are there, but it didn't grow well. So he have X-rayed and real picture. His question is it possible to recreate functional and better aesthetic fingers for her? Although it is difficult to just, fulfill his expectations without photo and X-ray, but then you just try to respond. Dr. Baek.
Okay, of course. So can I see that X-rays now, or you may send me an email with the informations?
Yeah, it's not possible. I think later after the webinar, if we share our email, then he may. Oh,
Okay, no problem, no problem.
yeah, right. Okay. So how do you show the picture? You would post a file? I'm not quite sure. All right. So without photo or X-ray, would you respond on this? Maybe you could guess.
I'm not sure, because at least I need a simple X-ray.
Right. Yeah. Well, sorry, Fernando, we do not expect for this forum to have consultation because this is a webinar for doctors. I'm so sorry for that. But later you could approach us. You could Google our data in the email, and if you look into our website, I mean my personal website, you could also send email to me and also to Professor Baek. He is actually the active professor in the Seoul National University, the Department of Orthopedic. I'm in the Department of Surgery under the Divisions of Plastic. You could just send email to us. Dr. Baek, I still have questions. There are potential surprises in the practice of hand surgeons dealing with congenital hand differences. We may think that we have done our best with the best outcome we have performed. I think we could confirm it by the literatures, EBM. However, patient may not be so happy like you shown in your presentations, knowing that he or she demands normal parameter, comparing with the normal people. It could be in the form of wanting 5-digit hands instead of 4 in hypoplastic thumb, as an example, when you do your policizations as an example, or wanting a normal looking thumb in slanting or slender thumb, or the sophisticated toe to hand transfer that made the patient more functional and enjoyed increased well-being could still be seen by the patients as his or her hand looks worse or very much worse. On the other hand, a patient with upper hand is happy to have 5-digit hands, as you have clarified through your lecture, even though he or she has severe limitation with the stiff hands. These situations needs attention for better future treatment. In this case, I believe future regenerative medicine, precision genetic engineering, and also surgery might be our future to go along with fetal laparoscopic or robotic surgery, beside the existing pre-marriage counseling to reduce the number of the involvement of genetic and hereditary problems. So what do you comment on that?
That's a really tough question, because we don't know about future technology, especially genetics. I don't much have knowledge about the genetics, but I think personally, if you can make fingers, that means you can make a human.
Right.
So I used to tell the residents and students that there are 2 possibilities. 2 trains are running very fast to get the goal. One is the engineering. The other is the biology. So like Iron Man or RoboCop, the hand can be made by some good machine. So a good machine can replace deficit hands. The other one is the tissue engineering. You can multiply the bone tissue, tendon tissue, skin tissue, whatever, and then make it like a finger, and then replace the tissue engineered finger into the defected one, defected side. But I think the machine will win the game, because if you can make the finger, that means you can make the human, because in the finger, there is everything, nerves, vessels, and tendons, skins, bone and joints, whatever. So it is very complex tissue. not like liver. Liver, we have only hepatocyte and Kupffer cells, two types of cells. It's easy to make, but if you would like to make fingers, you have to make everything.
Right.
Make fingers. So I'm not sure, but I think the deficit human hands or feet can be replaced by the machine.
Right.
Probably a century later, there will be some technology to make real fingers. But recently, I mean, 10 years later, 20 years later, probably I think the machine hand or fingers will replace the deficit part.
Let's see. Well, thank you very much. Go-Hyun, you
Okay.
are my champion this evening.
Thank you.
Our evening time. Ladies and gentlemen, let's give big applause for Professor Go-Hyun Baek for his excellent lecture. And his
Thank you.
generosity by responding the questions. I thank you very much to all of you who participated in this webinar. Like I mentioned, I'm so sorry that we do not provide you with a game session this time, because this is quite tough to pick, which point to be for the game, to be in the questions for our game. But, I promise for the next webinar, we would again come with game for you. Thank you, everyone.
You.
Stay healthy and well. Go-Hyun.
Thank you. Good night.
Good night.